So our next speaker will be Dr. Joyce O'Shaughnessy from Texas Oncology. And the title of her talk is Overall Survival Subgroup Analysis by Metastatic Site from the phase 3 MONALEESA-2 study of first-line ribociclib and letrozole in postmenopausal patients with advanced hormone receptor positive HER2 negative breast cancer. Joyce.
Thank you, Angie. Thank you, Bill. Good morning, everyone. It's a pleasure to be here in person with everyone. I'm Joyce O'Shaughnessy from Baylor University Medical Center, Texas Oncology, and U.S. Oncology Research Network. And today, I'll be presenting a subgroup analysis by metastatic site from the MONALEESA-2 trial. These are my disclosures. The final overall survival analysis for MONALEESA-2 was recently presented at ESMO and reported a statistically significant overall survival benefit for first-line ribociclib plus letrozole over placebo plus letrozole in postmenopausal patients with hormone receptor positive, HER2 negative advanced breast cancer. Today, I'll be presenting an exploratory overall survival subgroup analysis from MONALEESA-2, evaluating subgroups of patients of clinical interest by location and number of metastatic sites and by prior therapy in the neoadjuvant and adjuvant settings. MONALEESA-2 enrolled postmenopausal women with HR-positive, HER2-negative advanced breast cancer who had had no prior endocrine therapy or chemotherapy for advanced disease. Patients were randomized 1-to-1 to receive either ribociclib plus letrozole or placebo plus letrozole. The primary endpoint of progression-free survival and key secondary endpoint of overall survival have been previously reported. Here we see the results of the final MONALEESA-2 overall survival analysis in the intent-to-treat population presented this year at ESMO. A median overall survival of 63.9 months was observed in the ribociclib arm versus 51.4 months in the placebo arm, with a hazard ratio of 0.76 and a statistically significant p-value of 0.004, which crossed the pre-specified Landametz boundary of p less than or equal to 0.0219. The median overall survival in the ribociclib arm is the longest reported in any phase 3 clinical trial for advanced breast cancer and the first to exceed 5 years. Ribociclib improved overall survival by 1 year compared with those treated with placebo, and the difference in survival rates between the arms increased over time. The data cutoff for this current analysis was June 10th, 2021, with a median follow-up of 80 months. This overall survival analysis included pre-specified subgroups, including those with bone-only metastases, liver involvement, lung or liver involvement, number of metastatic sites, prior chemotherapy, and prior endocrine therapy. Hazard ratios were estimated using stratified and unstratified Cox proportional hazard models. Importantly, this was an exploratory analysis and as such wasn't powered for significance or adjusted for multiplicity. Patients, both with and without bone metastases, had an overall survival benefit with ribociclib plus letrozole over placebo plus letrozole that was consistent with the overall survival benefit observed in the intent-to-treat population. The estimated 5- and 6-year survival rates are shown and demonstrated a notable improvement with ribociclib compared with placebo in both subgroups, with and without bone metastases. The hazard ratios of the two subgroups were very similar and were consistent with the results in the intent-to-treat population, with a hazard ratio of 0.78 for patients with bone metastasis and 0.77 for those without bone-only metastases. Shown on the left is the subgroup of patients with liver metastases. No difference in median overall survival was seen in this subset, but there was a late separation of the survival curves. The 5-year survival rates for ribociclib versus placebo were 37.2% versus 28.4% respectively, and the 6-year survival rates were 31.0% versus 18.9% in patients with liver metastases. The hazard ratios for overall survival were similar in the two groups at 0.81 for patients with liver metastases and 0.77 for those without liver metastases. The presence or absence of liver or lung metastases was a stratification factor in the trial. Similar to the data in the liver metastases population, the survival curves separated at about 48 months, and landmark analyses showed survival benefit with ribociclib at 5 and 6 years. In patients with liver or lung metastases, the 5-year survival rates for ribociclib versus placebo were 48.2% versus 45.4% respectively, and the 6-year survival rates were 40.5% versus 31.2%. For patients with and without liver or lung metastases, the hazard ratios for survival were 0.81 and 0.71 respectively. Survival was also analyzed in patients with less than 3 metastatic sites of disease and those with 3 or more metastatic sites. The hazard ratios for survival were 0.71 in the 3 or more subgroup and on the right, and compared with 0.78 in the less than 3 site subgroup on the left, consistent with the results in the intent to treat population. The estimated 5 and 6 year survival rates are shown for both subgroups, showing long-term survival benefit with ribociclib. Similarly, the overall survival curves show benefit with ribociclib regardless of whether or not patients had previously received adjuvant or neoadjuvant chemotherapy. In patients who had received prior chemotherapy, the hazard ratio for survival was 0.74, and it was 0.78 in patients who had not received prior chemotherapy. Finally, survival was analyzed in patients who had received a prior aromatase inhibitor, tamoxifen alone, or sequentially with an aromatase inhibitor, and those who had not received prior endocrine therapy. In these subgroups, ribociclib plus letrozole demonstrated improved survival over placebo plus letrozole with hazard ratios of 0.63, 0.86, and 0.70 respectively. It's important to note that the subgroup of patients who had been previously treated with an aromatase inhibitor is small, with 53 patients, so confidence intervals are wide around the 0.63 hazard ratio. In conclusion, independent of metastatic site, bone, liver, lung, or liver, number of metastatic sites, less than 3 or 3 or more, or prior neo or adjuvant chemotherapy or endocrine therapy, this exploratory subgroup analysis demonstrates overall survival benefit with first-line ribociclib plus letrozole compared with letrozole plus placebo in postmenopausal patients with hormone receptor positive, HER2-negative advanced breast cancer in the MONALEESA-2 trial. Consistent improvement in long-term survival at 5 and 6 years with ribociclib was observed in all subgroups analyzed. MONALEESA-2, 3, and 7 have demonstrated a consistent overall survival benefit with ribociclib regardless of endocrine therapy partner, line of therapy, or menopausal status. I would like to thank the patients who participated in MONALEESA-2, their families and caregivers, and the study investigators and staff at each of the trial sites. Please scan the QR code for a copy of this presentation. Thank you for your attention.
Thanks so much, Dr. O'Shaughnessy. So we have several really interesting questions from the audience. So first, is there any explanation for the late curve separation, particularly in those with liver and lung metastases? And to what extent do you think this benefit reflected ribociclib versus the drugs that were subsequently used for these patients?
Yes, if you look at what came afterwards, it was pretty well balanced, as we'd expect, but it was 34% of patients on the placebo arm received a subsequent CDK4/6 inhibitor versus 21% on the ribociclib arm, so a little bit of an imbalance there. But otherwise, it was pretty well balanced. And so I don't know, I was looking at that and thinking about it. It kind of appears that with the late separation, you'd think that it was really helping patients who had the most endocrine therapy sensitive disease, and not so much early on for patients with disease that was patients were destined to have a shorter survival. Having said that, we just saw, from Lisa, really nice improvement in patients with the luminal A breast cancers. So it's a little bit of a mystery. At the end of the day, these are exploratory. The numbers are relatively small, et cetera. And the stratification was based on patients with liver or lung mets, but these are not all stratification factors, so there's going to be some variability.
Great. And several of our viewers are asking about CNS disease. Do you have any data on benefits to, or lack thereof, to patients who had CNS metastases?
No, we don't. And it's pretty unusual. We don't see that many patients with HR positive, HER2 negative breast cancer with brain metastasis. And I've not seen data on that. We're pretty mature now, too, with 80 months median follow-up.
Great. A viewer from Belgium asked, during ESMO, we learned that the overall survival results in the metastatic line 2 were driven by de novo metastatic disease, with very little to no effect in those with secondary metastatic breast cancer. Do you have any sense of that as you look at the longer follow-up? Will we have overall survival for this group in particular, de novo metastatic disease?
Yes, in Gabe Hortabaji's presentation at ESMO, in the forest plot, there are point estimates for those with de novo metastatic versus non-de novo metastatic, so recurrent disease. The point estimate is definitely in the direction of the de novo metastatic patients. In fact, there was a separate publication looking at the progression-free survival in the MONALEESA-2 because the de novo metastatic patients did remarkably well, and so it looks in that forest plot like the patients who had recurrent disease just didn't do as well. It's not statistically significant. There's no significant interaction. So if you look, however, at the MONALEESA-7 and in the MONALEESA-3, in fact, Professor De Laurentiis has a poster here looking at this issue of de novo metastatic versus recurrent in both the first line and the second line of the MONALEESA-3. And all of those trials, there's really no difference there between the de novo metastatics and the recurrent patients. So I think that it's probably the play of chance. There's probably some imbalances, but it wasn't a stratification factor, so it's probably some imbalance. But if you look at the totality of the data, you just can't convince yourself that there's any real difference between the de novo metastatics and the recurrent patients.
Okay. We also have a question about ESR1. And so the question for these patients, particularly those with the in the liver metastases group, who had such a long, which is wonderful, such a long survival. Do you have any data on ESR1 in those patients, whether that may have played a role in their benefit?
We don't yet. There is a lot of ongoing analyses. As you know, these are going to be a real fruitful area of translational research, both in the blood, sequentially over time, as well as the tumor. But I have not seen data yet on ESR1.
Great. Well, thank you so much, Dr. O'Shaughnessy,
Thank you very much. My
for
pleasure.
that great
Thank you.
presentation.